All right. So the reason I created this presentation for you guys or generally for everyone is because this is a question I often get, like, cycle design, like what's a good first cycle? And as people become more curious to the possibility of going enhanced, I had the good fortune of having good guidance, but I notice a lot of people don't. And then this is me kind of giving back a little bit of like my experience, what I've learned in terms of cycle design. So you want to do a cycle, watch this before you start. So by the end of this, we should all be able to address these four questions. And the questions are, what are steroids? What are they not? What are some pros and cons of them? And how to come on and off of them? And I also have to insert here a little disclaimer that I am not a doctor, nor am I recommending steroids. This is just my knowledge and my personal experience, what I've gone through with myself and some of my athletes. So let's get into it. So first off, what are steroids? Because everyone kind of tosses this word around. So I just want to define it accurately for you guys. And steroids are exogenous bioidentical molecules to hormones in our body. So here we have exogenous, meaning that they come from outside of the body, bioidentical, meaning that they have the same structure as these hormones. And what are these hormones responsible for? Growth and development, metabolism, sexual function, reproduction, mood, blood sugar, blood pressure, fertility, sex drive, sleep. Like, we kind of associate all of these with testosterone, but testosterone isn't the only hormone out there, and anabolics aren't the only type of hormone. There's actually three different classes. And these classes are proteins and polypeptides, steroids, and then tyrosine derivatives. So those are the three classes. So protein polypeptides, these are water-based hormones. So, and these encompass like most of the hormones we have. And the difference between, or what's unique about proteins and polypeptides is that they have receptors on the outside of the cell because they're water-based. Because they're water-based, they have a hard time going through the cell membrane because that's oil. So all of their receptors are on the outside. And then they have a second messenger within the cell that then goes to the nucleus and expresses whatever change it's supposed to do. So for example, growth hormone. Growth hormone gets converted into IGF-1, insulin-like growth factor 1. And that is what mediates the changes that we associate with more muscle or more amino acids going into the muscle and like muscle growth. Then there's also insulin. Insulin doesn't interact within the inside of the cell. There's actually GLUT4, which is what interacts within the cell and transports glucose throughout the cytoplasm. Like, that's what's active. So what we know there is that these interact outside of the cell, and they're water-based, which is different than steroids, because steroids are cholesterol-based molecules, and these have a sterile backbone. Like, these are the things that we hear everyone talk about. Like, toss a random anabolic out there. Randy, give me a random name of an anabolic that you know.
Tren.
There you go. That's an example of a steroid. All of these are examples of steroids. And they all have a steroid backbone. They all kind of use testosterone as the base or cholesterol as the base molecule, testosterone from that. And the difference is that these, because they're fat-based, they can go through the cell membrane, so they can interact with the nucleus of the cell directly. So for example, testosterone, how does it increase protein synthesis? Well, it goes into the nucleus of the cell. It says, hey, we need to produce more actin and myosin. Actin and myosin, like, if we really want to dig into it, those are the little parts that kind of slide back and forth within the muscle. They create more of that. That is what protein synthesis is in a little scale, but then it's amplified to like hundreds to thousands of times, and that's what creates muscle growth. So those are steroids. They're oil-based. And then we have the tyrosine derivatives. And these are just hormones that are composed of tyrosine amino acid, and they act like both. They can act like either a protein polypeptide or a steroid, depending on which hormone it is. For example, T3, T4, that's thyroid hormone, the active and the inactive version. That it acts like a steroid. But then we have the catecholamines, which act like peptides. The catecholamines, that's the epinephrine, norepinephrine, that's like adrenaline. and we have dopamine as well within that. So you can see here that steroids isn't just one thing. Like when a competitor's in a contest prep, T3 can also be utilized, but that's not a steroid, but that's not a cholesterol based steroid anabolic, but it's still like a steroid. It's still a hormone. And another thing that we can kind of use here that I'm not going to talk about today, but it's that everyone wants to just throw anabolics into a body to grow. But we've just shown that polypeptides are also a viable source of creating growth. It's a different hormone. So why wouldn't you utilize other parts to create anabolism? Like anabolics isn't the only way to grow. It's for sure the best bang for your buck, but long term, it's not going to bring about the best health benefits. So now that we've defined steroids, see what they are, let's focus on the one we're going to talk about today. What hormone are we going to talk about today? And that's testosterone. And why are we going to talk about testosterone? Because I would say that the safest route on a first cycle design would be to just do a testosterone base. There is no need for bringing in a DHT. There is no need for a 19 nor for all these other types of anabolics. Just a testosterone base will suffice. So what is testosterone then? Well, testosterone is a hormone that's responsible in males for both the primary and secondary sexual characteristics. And the reason I want to differentiate these is because as we go through the presentation, you guys are going to kind of see how testosterone and the cycle affects these. So the primary sexual characteristics, these are associated with like reproduction. So before we're born, when we're like in the embryo state, like in the really, really first trimester, there's an initial spike of testosterone, which then determines that you're a male. So that initial spike of testosterone then initiates the cascade of events that develops the male reproductive tract. So that's why testosterone is important there as a primary sexual characteristic. Also, it's important, vital for developing spermatogenesis. And those are the primary sexual characteristics. Those are like the reproductive ones. Then there are the secondary ones. And these are what we can refer to as the androgenic effects. And most of these come about after puberty. So these are like the bodily hair, the deepening of the voice, the male fat distribution, and the muscle growth. So from like, if you guys ever got picked on by your older sister or something like that, when you were younger, but she couldn't pick on you after puberty, it's because of these sexual characteristics. You ended up getting a lot bigger than her, and that's because you had a spike in testosterone. Up until that point, up until like before puberty, you guys were about the same body size. You guys had about the same muscle distribution, but that changed. So that is testosterone. So where does testosterone come from and where does it go? And we're going to separate it into two parts here. The first one is really important for understanding the PCT, post-cycle therapy, and understanding fertility. So we have the hypothalamus, pituitary, testicular axis. This is the HPT axis. So what happens here is the hypothalamus sends gonadotropin releasing hormone to the anterior pituitary. That releases LH and FSH to the testes. LH, luteinizing hormone, FSH, follicle stimulating hormone. So the LH goes to the Leydig cells, which then produce testosterone. And that increases intratesticular testosterone. There's a difference between intratesticular testosterone and total testosterone. Just want you guys to note that difference there because that's important for fertility. So that's what LH does. And then FSH, that increases ABP. That's androgen binding protein. And that's through like the Sertoli cells or some shit like they're called something. But together they create sperm. So that's the first part of the axis. But then once you have testosterone here, like free testosterone that doesn't undergo spermatogenesis and isn't bound by SHBG, sex hormone binding globulin, something that we don't necessarily need to know too much about right now, but whatever's free can then convert to different things. And these conversions happen within the cells. So testosterone goes into a cell. It can either interact with the nucleus directly, or it can turn into a metabolite. And what are these? Well, it can turn into estrogen via aromatization, or it can reduce into dihydrotestosterone via 5-alpha reductase. But then as an intermediary between the estrogen, there's like a metabolite that can also be produced from that called nandrolone. That's the 19-nors. So you guys, now that you kind of see where it comes from and where it's going, you kind of see these different terms that are used in like anabolic culture, like the steroid culture. They're like, oh shit, a DHT, I've heard that before. A nandrolone, 19-nor, I've heard that before. This is what they are. They naturally occur within the body. We're just creating them synthetically and administering them into our bodies. So that's where it comes from. All right, in the water break, I made sure to put these in here because I get to talking really fast and I forget to drink my water and slow the fuck down. So that's for everyone. See, Randy took a good swig too. Hell yeah. Stay hydrated, brother. All right, let's move on to part number 2. There's only 3 parts. All right, what are the pros? Like, what are the pros of having super physiological levels of testosterone? I mean, these things don't just happen with super physiological levels. Like, this occurs for somebody that has normal levels of testosterone, but increased protein synthesis. So there's more amino acids being pulled into the muscle. Because there's more amino acids, there's also more transcription happening. Transcription is that copying of DNA. And that copying of DNA is that actin myosin we talked about previously. And then there's also more fat loss. So more fat is used via inhibition of deli-lipoprotein lipase, and less fat stored via increased number of beta adrenergic receptors. So basically what this means is that instead of fat that's in the blood being uptaken and stored, it's kind of blocking that passage so that that fat stays in the system, in the circulatory system, and it gets oxidized. It has to get used. So that's how it increases fat loss. And then increased performance because it increases DHT, which is 7 times more androgenic than testosterone. That's what brings about the increased training performance. And that's through the effects on the central nervous system. Because the central nervous system is basically what it's like the connection between the mind and the muscles. So whenever we develop better whenever we're like practice a new lift and we're like putting on 10 pounds week after week, it's not that we got put on that much muscle to be able to lift that much weight. It's that we developed a better neuromuscular connection with that movement. Therefore, we become more efficient in moving that load. That's sort of what DHT does. It just creates better engagement. And that's like another advanced thing that we can talk about in a later presentation, why you might want to use a certain kind of DHT or a 19-nor respective to a cycle, because you want to bring about certain benefits like, and in terms of gut health, CNS, like that's more like what DHT interacts with and how it can be used. But DHT is also used in like brain. It's important for brain and libido. So something I want to know is like, because DHT is 7 times more androgenic, it's also what leads to a lot of the negative side effects that people associate with anabolics. But we need DHT. We can't live without it. So the last part here, the last kind of pro that I would consider for anabolics is that it increases libido. So more blood flow via dilation. So all it does is it increases nitric oxide, which dilates the blood vessels. When they dilate, get smaller, that means that there's more blood pressure. When there's more blood pressure, it creates the erection. Another thing which could be a pro, I consider it a pro, is that in the 1960s, when it was originally starting to get created within the lab and studied, it was actually thought of to be like a male birth control because of the negative effects or the suppression it had on the HPT axis and the production of sperm. So for some people that might be a pro, for some people that might be a con. I just put it under the pros. All right, so let's get to the cons, because it's not all like sunshine and rainbows. Like there's something bad to every good. And I want to differentiate these based on two things. Like the first one is the internal side effects, like what happens inside the body. And the other ones are superficial side effects, like what happens outside of the body, like over the skin. Let's start with the internal side effects. So the first thing that's affected and the thing that's most affected is hematocrit and hemoglobin. So that is the percent solid to liquid in the blood, hematocrit, and then hemoglobin, which is how many red blood cells we have. So erythropoiesis is what testosterone stimulates. That is the production of red blood cells. And because we have more blood cells, more solid within the blood, that means it's denser. When it's denser, that means that we increase blood pressure. And this is one of the biggest biofeedback markers that we actually have to check while we're on a cycle, the blood pressure, monitoring that. Then it also negatively affects lipids and cardiovascular health. So what does it do? We know it decreases HDL. HDL is the good cholesterol, the one that comes around the blood vessels and picks up the extra the extra platelets, the extra kind of like residue. But we decrease that with testosterone use. And then also in a lot of cycle designs, people bring in AIs, which are like the aromatase inhibitors, because they bring down estrogen in order to manage the negative effects of estrogen. But the thing about estrogen is that it's cardioprotective and neuroprotective. So when people utilize AIs, they're doing themselves a bigger wrong when they could just go about it in a different way. We'll talk about that in a little bit as well. And then the last con here was the HPT suppression that's occurring and infertility. So what I said is because we don't have that luteinizing and follicle stimulating hormone anymore, that means that the testes aren't getting a signal to produce testosterone. Why? Because we have exogenous testosterone being introduced. So it escapes the testes. Like there is no testosterone in the testes. So there is no sperm being produced. That's another side effect, or that's another con of. And then we have the superficial side effects, which are those that happen over the skin. First one, acne. So we have the 5-alpha reductase, which is the thing that converts testosterone into DHT. So there's more of that within the skin. And because of that, that means that more testosterone gets converted into DHT. So the thing about testosterone is that it's free to go wherever it wants to go in the body. It doesn't just go into the muscle. It goes everywhere. It goes into the skin. It goes into the scalp. It goes into the prostate. It goes everywhere. And it can express itself into any of those receptors, or the androgen receptor, but it can express itself into any of those tissue, and it'll create whatever response it's meant to create. And a lot of these responses aren't good. For example, like when it binds to the androgen receptor and goes about DHT and goes into DHT, that it increases sebum production. Sebum production increases oil. Oil is what usually gets clogged in, what kind of nourishes bacteria, and that's what creates acne. But it's not this kind of sebum. It's a different kind of sebum, by the way. And then we have the thinning of the hair. So like what DHT does is follicular miniaturization. So it basically makes our hair follicles smaller and smaller until the point where the hair follicle or the hair just falls off. That's another negative side effect of. And then the gynecomastia. So because there's more testosterone, that means that there's more testosterone that's able to be aromatized. Aromatization is that process I talked about where testosterone converts into estrogen. So that just means more estrogen. And when we have more estrogen, that means we have a greater risk of developing man boobs. So what man boobs look like, it looks like a little bit of a pocket of excess tissue right under the nipple. I mean, if you look at bodybuilders, Sebum doesn't have one because he responds really well to anabolics and probably doesn't need as many as the average person does to get that kind of muscularity. But if you see like other bodybuilders that have taken it to the extreme, you can see like tissue that's developing there. It's like a second boob. That's gynecomastia. So those are the cons.
From a
Ooh,
lipid standpoint.
let me pause that right there. So now that we know what testosterone is, what it does, what is it not? Because a lot of people have a misunderstanding of what it is. And I just want to say that testosterone is not a magic pill or a fad. That's to say that in order to get the results that you think testosterone is going to give you, you're going to need to prioritize your lifestyle components. And these are going to need to be optimized. So what are these lifestyle components? And I'm going to make them as simple as I can make them. From a nutritional component, you're going to need to maintain an optimal body composition with a clean and consistent diet. So I just said how testosterone aromatizes into estrogen. That is done via the aromatase enzyme. That's an enzyme that's produced in adipose fat cells. So the more fat we have, the more aromatase enzyme we have, so the more testosterone that's converted into estrogen. That's actually the problem with obesity and hypogonadism, excess body fat, which leads to excess aromatization. That's the core of their problem. So we don't want to run into that issue by having an improper body composition. Also, keep in mind that insulin sensitivity, it's a concept that you guys may be familiar with, but it's how responsive the cells are to the insulin hormone. Insulin sensitivity decreases as body fat goes up. So you want to stay tight. You want to stay lean in order for this to fucking work. All right. And then in terms of training, prioritize proper execution. So muscle grows a lot faster than connective tissue. So when you have a muscle that's a lot stronger than the connective tissue that's holding it, you can eventually end up tearing a pec. So that's why execution is important. That's why making sure that you eliminate momentum from movements is important. Making sure you have control of the load is important. Working with the appropriate intensity is important. And then also doing your cardio, because cardio is the best thing that's going to maintain your lipid health. Making sure that you have good cardiovascular endurance. Just because you get more fat loss from testosterone doesn't mean that you can stop being active and stop doing cardio. Then the last component here is recovery. Like, prioritize your sleep, get tissue work done, and focus on those parasympathetic activities. The parasympathetic activities are those that are just like the chill ones, just journaling, going on walks. Like, in no way should testosterone be a way for you to forget about the things that are fundamental. And these are the things that are fundamental. So once these are nailed, once you have these things down, and this is something Matt Jansen told me. Matt Jansen is the guy down here. And if you don't know who Matt Jansen is, he's one of the best or second best bodybuilding coach in the world right now. He said, before you go enhanced, you should learn to grow without them. So if you don't know how to put on muscle without anabolics, what makes you think that it's going to be optimal for you to get on a cycle and put on muscle when you don't even know how to do it in a natural environment? Like, yes, you're going to get results, but you're not going to get the results you want. So that's the first part. The second one is, it's not a fad. Like, this is a serious financial and health responsibility. Like, you're basically taking control of your hormones. You're taking control away from your body and saying, I got this. I will supplement whatever hormones I need to keep myself in check. You're taking that away from the body and you're giving that responsibility to yourself. So that means that you have to take care of yourself. You can't just miss pins. You can't just go a week without pinning. You can't just kind of discard this and think that you can come on for 2 months and then come off without any repercussions at the back end. Oh, and then this is just me further validating the point that you need cardio, and cardio is one of the most important things for making sure that your lipid health is sound, or it's healthy.
Point, I would argue that improving your cardiovascular conditioning is going to do more to improve your lipid panel than any supplementation will ever do. Okay, so whenever I see an individual that has very skewed numbers in terms of their heart health, I'm always driving up and increasing the intensity and duration of cardio and then I put the supplementation in behind that to support it.
Yeah. So, I mean, I learned a lot from Matt Jansen. The guy's fucking brilliant. All right. Oh, another water break that I had already taken. But all right. So far, have I lost some of you guys? Don't worry. There's a Q&A at the end. So if there is some parts that you want clarification on, we will go over those, and I'll go over those with you guys in detail if you need me to. All right. But this is part number 3. So we've learned everything about testosterone. We know what it is, what it isn't, where it comes from, what it does, what other types of hormones there are. How do we actually come on? Like, how do we get on a cycle? Well, the first part is you need a 3-step checklist. And the step checklist is lab work, get your supplies, and slow and steady. So lab work. Before you start your cycle, you have to get your blood drawn. Why? One, we need to make sure that we're healthy internally. Like I already said, how going on a cycle is going to skew your biofeedback markers. If these are already skewed, if these are already not optimal, you're just going to exacerbate an issue. And this, I mean, if you're overweight and you have your lipids are off, this might not be the best route. You know, if you already have some form, you've already have some form of hypertension, you don't want to, get on a cycle and further exacerbate that issue. So you need to make sure that everything's in check. And then also you need to understand your family history. So know if you're predisposed to certain conditions that can be worsened by the use of anabolics, cardiovascular disease, heart attacks, stroke, prostate cancer. Like these are all things we have to consider. And then get a complete hormone panel. Why? Because this is going to be important for your PCT. Your PCT is your post-cycle therapy, what you do on the back end. So like in order to know where you need to come back to, where your body was at homeostasis before you started introducing exogenous hormone, you need to know that. Because otherwise, where do you go back? How do you know where your LH was? How much LH was being released in order to stimulate the right amount of response, the right amount of testosterone where you feel comfortable? Where was your estrogen? Where was your SHBG? Like these are all things you need to know in order to get back to that homeostasis. And this doesn't just mean total testosterone. This means everything. This means estrogen. This means that SHBG. This means that FSH and that LH. All of these are important in order to go through that PCT. So you might as well have them. And then also something that I do want to note is that most males have their peak testosterone levels between the age of 20 and 25. So if you're not competing, I would just ride the natural wave as long as you can. Like there is no need to alter what's already happening within your body. Like within the early 20s, your body's still developing. Your hormones are still finding that comfortable homeostasis. Don't alter it for just the need of wanting to get bigger. Like leave that for something in the later stages of life. Once you've developed a little bit more muscle maturity, then you'll see a lot more benefits than had you started early. But everyone wants instantaneous gratification. This is me telling you, instant gratification doesn't take you anywhere. All right, second step here, get your supplies. So what do we need? We need health supplements. We need ancillary drugs, and we need medical supplies. What are our health supplements? Vitamin C, omega-3, and betaine HCl. Vitamin D, we're going to have testosterone decreases your immune system, compromises your immune system. So we need to make sure we have some immune system support. Omega-3s and lipid supplements. We've already talked about how it increases cholesterol. It also increases inflammation. So we want to mitigate that as much as possible. Then betaine HCl. This is used for digestion. So testosterone decreases stomach acid production. So you're going to if you have a hard time digesting food, introduce betaine HCl in order to help that. Then we have our ancillary drugs. We shouldn't get to the point where we need to use these because we should manage our side effects with the dose itself, something that I already noted. So what are these auxiliary drugs we could have on hand in case shit hits the fan? Telmisartan, that's an ARB, androgen, angiotensin receptor blocker. All it means is that instead of instead of constricting the blood vessels with angiotensin, that's what angiotensin does, it's going to restrict, or it's going to block that hormone. That way the blood vessels open up. When the blood vessels open up, that means they get wider. That means blood pressure decreases. So that's what telmisartan does. It decreases blood pressure. That's directly addressing the hematocrit and hemoglobin problem that would develop. And then we also have arimidex, aromazine, letrozole, and even clomiphene, which are examples of AIs and SERMs. These are the estrogen management tools. I noted them differently because they all have a different mechanism of action, and they're not the same thing. But that's not something that we actually, well, that's not something that we can dive into today. But just know that these side effects that we experience, they should be mitigated with the dose. So like once we get into the dose, you'll kind of see what these reference ranges are. But then the last part here is medical supplies. You need your needles, your syringes, and your alcohol wipes. In terms of the needles, if you look here, there's a diagram of the different sizes of needles. So the lower the number, that means the thicker the needle. We want to use a thicker needle to draw out the oil, but then use a thinner needle to actually introduce it into the muscle. And then your syringes, you have 1 milliliter or 5 milliliter ones. Usually, I mean, you probably want to get the 5 milliliter ones. For TRT, 1 milliliter works. And then alcohol wipes. So these are your supplies. Now, slow and steady, how to actually do it. Dose, duration, frequency, and administration. Let's cover them. Dose. You want to start at about 150 milligrams per week and titrate your way up to about 500 milligrams per week. Where this is depends on how big you currently are, how much muscle you currently have, and what the side effects are leading up to that higher dose. So somebody that's bigger, somebody that has more muscle, they probably need a little bit higher of a dose. Somebody that's smaller, they probably don't need that 500. Another thing here is that it depends on these side effects that we were talking about. The estrogen management, initially the estrogen management. If we start developing excessive water retention, if we start developing gynecomastia, if our blood pressure starts increasing drastically, this is how we mitigate it with the dose itself. We don't need to bring an AI or an ARB. Like, let's work on the dose first. More is not better here. So I think about it this way: easy come, easy go. So you're not always going to be on a cycle. You're eventually going to bring those levels back down. And muscle that comes on fast doesn't mature. Therefore, it could come off just as fast as it came. Therefore, slow and steady is better. And then check one thing that I also want to note, check the concentration of the oil. So the oils are dosed between 200 and 300 milligrams per milliliter. I fucked up the first time I ever used it. Because of the dose. I didn't really look at the dose, so I just put that in there so you guys don't make that same mistake I did. But then duration, as long as you can mitigate the negative side effects, that's usually between 16 to 40 weeks. So the negative side effects we already talked about, it's like the biofeedback, the hypertension, the inflammation, gut health is another, gut issues, another thing, how I said that it decreases stomach acid. So you start developing gut health issues. You start getting some form of SIBO, you get indigestion from pushing food maybe too much because you're also at a calorie surplus. Your metabolism is cranking really fast. So you're going to be a lot hungrier, which means that you're going to push a lot more food, which means that there's more stress on the gut. So there's a lot of things that can that basically note, okay, this is the end of the cycle. We can't grow anymore, because if you can't eat, you can't grow, regardless of how much antibiotics you throw in there. If you're in an inflamed state, you can't grow. How do you get inflammation? You develop it from having like super physiological levels of testosterone. It's something that accumulates, almost like fatigue. So it's a big range here, but 16 to 40 weeks depends on these biofeedback markers. I think my first cycle was for about 40 weeks. So that's what it did. And it stopped, and we cut it short because of, or we cut it. We ended it because of blood pressure. My blood pressure was getting too high. So that was my ending right there. And then frequency. Frequency depends on the ester. How often you pin. This depends on the ester, or like the molecule that's attached to the testosterone, which basically clives off and allows it to interact with tissue. That's what an ester is. And this depends on feasibility and also what's like biologically sound. So feasibility, we technically have a release of testosterone every day, but we don't want to inject every day. That sounds fucking like tedious. So we do it like maybe every other day, every 3 days. So that's the feasibility. And then also we want to make sure that it fits that happy medium of like we're injecting as many times as is feasible, but we're also getting as close as we can to what would be the natural rhythm of testosterone within our body. So we have the 3 common esters that are used are enanthate and cypionate, which usually are 1 or 2 times per week. And then the propionate, which is a shorter half-life, which is about 2 to 3 times per week. And the last part here is the administration. Where do we inject it? Let's switch out the locations. So here we have the shoulders, the middle of the delt. So if you put a triangle on your arm, on your delt, it would be smack dab in the middle of the triangle. Then you also have your upper outside thigh. So where the vastus lateralis would be, the top of the vastus lateralis, like that's a meaty part of the quad to hit. You also have your glutes. So if your glutes are separated into 4 corners, like 4 corners, you do the upper right corner, the meatiest part. Then you can also do your abdomen, how I talked about with like an insulin needle. But make sure you don't hit your abs, like your actual ab muscles, because that shit would probably hurt hella. So like that's the administration. All right. So now that we've talked about all of this, how do we come off of them? Because we can't always be on cycle. There's 2 options. And this is where you have to really decide what's best for you. You have post-cycle therapy, PCT, and TRT, testosterone replacement therapy. So post-cycle therapy, that's us restoring that HPT axis signaling to get the testes to produce testosterone again, naturally. So that's that. We kind of broke, if it's a 2-way bridge, hypothalamus to pituitary to testes, we've kind of broken one of those bridges. So we build that bridge back up. We re-stimulate that. What do we use here? We might need some ACG, some HMG, some Clomid, which is a serum, Arimidex, Aromacin, some form of estrogen management tool. With the HCG, HMG is a derivative of, but that's a different topic for a different day. Then we have testosterone replacement therapy. That's the indefinite supplementation of hormones exogenously to maintain homeostatic levels. So that means, okay, I have my body forever will not produce testosterone. So I commit myself to always replacing testosterone. And the route you take, just know that the longer you are on some form of exogenous hormone, the harder it is to get back to a natural state. So if you're just delaying it, if you want to go back to not having to ever inject again, it's better to go start that PCT sooner than later if you know you're eventually going to get there. If you've committed yourself to becoming a bodybuilder, to really seeking out this sport, then TRT might be the best route. So that's how you come off. I mean, I could definitely do a presentation later on how to do a PCT well, because that's also really important. But that would just be a whole nother hour presentation. So that concludes the presentation for today. But now here I have the video, April 15th, 2021, the first day I started my cycle. And something I want to say, which is just a general principle of how I see life, is that in life, there are no good and bad choices. Because if you look at a choice as good or bad, it depends on the time scale at which you're looking at it. So a choice that today seems good that I did a year ago, in a year might seem like a bad choice. Therefore, that doesn't matter. Let's just accept the choices that we did and let's move forth in the best way we can. And this is me moving forth the best way I can educating whoever wants to listen on how I did this properly and safely. So here's the video for y'all's enjoyment.
We fucking did it.
That shit kicked in immediately. All right. So that is the presentation for you guys. Do you guys have any questions? Any clarifications you need on any points? What y'all think? Give me something. Give me some feedback here.
I think it was a good presentation is because, especially nowadays, there's a lot of people who are like, oh, I'm just gonna do a cycle, whatever. And they have this whole misconception of it's gonna magically gonna give you gains. And they don't know that it could potentially harm them and it could be a lifelong decision they have to, deal with.
Yeah, and what I see often too is a lot of people they start with the harsh compounds right off the bat. Like I haven't even done Tren, and I've been doing this for 4 years. And I would probably won't use Tren. And Tren is a very specific compound. Like it has a very specific purpose. It's not even that good for muscle growth. It's better for anti-catabolic effects. So that's some shit you use on the back end of prep. But here you are, everyone's using it, trying to gain size.
Yeah. And then there's certain compounds that you just can't use together because then you get nasty side effects. Like if you use MPP and Tran together, you can get nasty gyno just because they're both.
Yo, that right there is the prolactin. They both interact with the prolactin receptor. So back to kind of like that conversion to estrogen. So you guys saw that 19 nor thing that was right there. So that actually the reason it interacts with the prolactin, it expresses itself with estrogenic side effects is because the prolactin receptor is very similar to the estrogen receptor. And NPP and all of that's a 19 nor. So that's why it interacts. But another thing about NPP is that, like NPP, that's a good compound within a reasonable dose to use on females. Why? Because females have naturally higher nandrolone levels than males do because they have higher estrogen levels. So they can respond to that better. It's like these are little things that you pick up from that I pick up from listening to like podcasts, from going to seminars, from doing fucking mentorships. And the thing is, like, this shit's a bro science. Like, no, you will never find a study on any of this. Like, for example, testosterone. Testosterone has never been clinically used on a human. But yet everyone fucking uses it. How? Because we try it on ourselves. It's the bro science. So it's like everyone discounts the bro science. Like, where's the research on this? Like, bro, there's no research. There's just 100 bodybuilders that have done this before, and all of them say this thing happened, and this is probably what we should use it as. So that's like the differentiator there. But yeah, you're right. Everyone kind of like just jumps into this without having, they're misinformed or they don't have enough knowledge. And this is me being like, hey, here's the education. Use it if you want.
Yeah.
All right. Anybody have any questions on the presentation? It seems like everything was really clear. VNA's like holding her head like, yo, that shit was confusing.
I have a question about something that wasn't on the presentation.
Yeah, go ahead.
So what category does SARMs fall into?
Selective androgen receptor modulators. So that would be depending on the all SARMs would be they'd probably fall under the steroids. They'd fall under the steroids, but all that means by saying SARMs is that it's just made to interact, or yeah, actually, it would be a steroid because it's interacting with the androgen receptor. The anabolics are what interacts with that receptor. So what a SARM is, what it's created to do is only interact with certain receptors. So in the way that I said testosterone, when it's free flowing in the blood, it can interact with any receptor on the skin, receptor on the scalp, receptor on the prostate, receptor in the muscle. SARM is basically like, okay, we've created this molecule to only interact with this receptor in this tissue. So that's what a SARM is, and it would fall under the steroids because it interacts with the androgen receptor.
Cool. That makes sense.
Yeah. And that was a good question, actually. It had me to I had to think back and be like, okay, let's define things here. Let's break it down. Any other question you guys have? That was pretty good.
Mhm.
All right, perfect. So if nobody has any more questions, thank you guys for all being here. This was probably one of the toughest presentations I've done just because of the sheer importance of this topic. This isn't just you giving somebody meal plan recommendations, like you talking about meal plan. This really affects somebody's health. But